All right. Welcome, everybody, to the Advocate Health Advisors podcast, the AHA podcast. Today, we're going to talk about some current events and recap a really exciting couple of weeks. So we just finished our annual meeting in Orlando. A wonderful job to Alissa and Jackleen and to Katie for putting that together. And we might reflect a little bit too on Medicarians because it was just a couple of weeks ago that we were all out in Las Vegas at the big annual event. So starting with you, Jackleen, what is happening with the clients? You talk to clients every day. What's some of the top things you're hearing of their interest?
Yeah, absolutely. So regarding the client care team, we have the privilege of speaking with hundreds of Medicare Advantage clients a week. So right now, and so we're helping them navigate, making sure that they got their medications in Q1, that they got in to see their primary care doctor. And so those are the key movements that we've been helping members with.
Great, thanks. How about you, Jennifer? What are you hearing from the agents and agencies in particular?
Yeah, well, I think right now they're still a little bit scared. We're still getting information coming out from carriers that are decommissioning plans. We've just heard about one, Clear Spring, that's pulling out of the Medicare Advantage market altogether. And, there's questions around that because it looks like there's going to be a special enrollment period of some sort, or maybe they'll have to work with CMS to pick a new plan. And that goes effective. Is it June 1st, Alissa?
Yes, that's right.
Did you learn yet, actually, before I move on, did you learn yet whether or not agents will be able to help their members with this, or if it's going to be something they have to do through CMS, like automatically enrolled, or?
I haven't seen a copy of the letter that the members are receiving yet for ClearSpring. I know on the ClearSpring website, it basically states that the member's going to be receiving a letter with further direction. And in fact, they might be proactively reached out to by a ClearSpring representative to help them. What we've seen historically is that when a plan exits in the middle of the year like this, for whatever reason, usually it directs that member to call a special phone number that is set up and a special website, if they choose to go that route, where they can have a new plan facilitated through that means. It doesn't open up an SEP. Usually that service area reduction SEP happens during the AEP timeframe and gives them some extra time after AEP. This is different when it happens in the middle of the year, where they usually get facilitated through a direct enrollment method.
And I guess if they don't take action, I saw also where they'll automatically be enrolled into Original Medicare and defaulted into a Humana Basic PDP. Is that correct?
That's right. Yep. They'll go back to Original Medicare and a PDP, which obviously probably isn't in the best interest of that member, because then they're left exposed to some more out-of-pocket costs.
Yeah, so I think what it's important is if you're an agent and you have any members that are in ClearSpring, is to do some, outreach to them and make sure you help them educate and make a new choice. Otherwise, they could just ultimately not have coverage that they might need, because Original Medicare and PDP might not be enough for them, right? So there was mostly people affected, from my understanding, in like Georgia, Colorado, Illinois. Those were some of the states that I saw, but if you're listening to this and you're an agent with us and you have any other questions, feel free to call in and we'll continue to provide more details when we know more about it. So Darwin, the other thing I'm hearing out there, or that we know that's happening, is that carriers are in their bid process. That's a very secretive process, right? They have until the end of this month to make decisions and work with their actuarial folks to decide what their plan design is going to look like for next year. So that is really one of the things that we're trying to prepare for, is to get agents ready going into AEP. And when we start to hear more things from when we start to hear more things from the carriers about what that might look like, we're going to strategize based on the state and opportunities that are out there. So.
Well, thanks, Jennifer. Yes, AEP will be here before you know it, and it's amazing how it sneaks up on you. So now is the time to get that plan together. Jennifer, at the annual meeting, you were with some of our carrier executives. What sort of things do you see on the horizon with the carriers, and what insights might you share from those one-on-one conversations that you had?
Yeah, well, one that you always talk about, which is, it's a quality game over quantity, right? So carriers really want to know that they are going to get the good quality enrollments. And, what does that mean, right? It means they want a member who's going to be engaged into their plan. They typically, carriers don't make money until a member has been enrolled for at least a year. Right. So if there's with all of these sort of switching and things, it can be costly for a carrier. Right. So they're looking for that. They want another way that we can have quality is that we have agents that are working in their communities, right? So they're doing not just the enrollment and education on the front end, but they're also doing those post enrollment services and things that Jackleen's team does, we can do to help them so that people know how to utilize their plan judiciously, as you say. So those are the things I'm hearing. I think that's exciting because I feel like 3 or 4 years ago, coming out of COVID, that we had a lot of these call centers and Joe Namath commercials and things, and lots of people were enrolling over the phone with a representative that was, licensed in a bunch of states and representing only like 4 or 5 plans. And the quality of those enrollments, the people didn't stay on the plans, and it wasn't good. And they said, "Oh, all you community-based agents or local agents are going to get replaced with a website and a call center," and that's not the case. So here we are. Those call centers are under pressure, right? Because their cost of acquisition on a sale is greater than they actually make. The math doesn't work on that. The quality and the education is just not there. And so there's no better time right now than to be an agent that is working in your local community to help members and to educate. And then to, most importantly, make sure once you do enroll them, you stay connected to help them with those post enrollment services. So,
Yeah, yeah, and it's amazing too that the carriers had two very simple things, right? Make sure your beneficiary client gets in to see their primary care doctor. They want everybody to have a primary care doctor, and they want you to help them unlock the plan benefits. So that sometimes is a rumor that they made the benefits hard to understand, but they're just trying to make sure everybody gets as much as possible. And if you give it all away, you don't have enough to go around. And so that's where we come in and we can help. I also thought that the carriers were emphasizing stability, and that the road ahead for them is to have more stability. Alissa, are we going to see any more changes though? Are there some bumps in the road with the IRA coming down and maybe some more drugs being mandatory?
Yeah, I mean, I think it's always a good idea to be like aware and cognizant of there probably is going to be some more things coming down the line. One thing we heard from, one of the carrier executives at our annual meeting is that the skies right now are kind of partly cloudy. It's a little murky, but that, obviously we're hoping for sunnier days ahead. So I think, hopefully the bids go well, but I think those carriers are still going to be tightening up those benefits. Some of the things that we've seen previously in plans might be removed, just obviously probably for economic reasons. And, just hoping that those sunnier skies open up and it's not quite so cloudy as it is now, but I'm sure that we're going to see some things down the line.
Well, and I think what the one executive that I was with said is that the sky is not falling. They might be
Right.
cloudy, but that the sky is not falling. I think that's a big takeaway
It
for our
is.
audience, is that the carriers and the government want stability. I'm going to get to Jackleen in a minute about John Brooks' speech on Medicarians, but Alissa, what does it mean to you when a carrier makes a plan non-commissionable? What are the tea leaves telling us there?
Yeah. When a plan goes non-commissionable to us, I think it could mean one of two things. Usually it's one, they want to slow the growth of the plan. The plan might be so competitive in a market, or due to other plan exits, it might be like the best thing going in that market. And the carrier wants to make sure that they can provide the benefits in a responsible way. And so they will want to slow the growth. So they might make those plans non commissionable. Another reason that we heard for making a plan non commissionable is that that plan likely might not be in effect the next year. It might be leading to a service area reduction where that plan won't be available in the next coming year. And that speaks to the stability that the carriers want. They don't want to disrupt a member's plan. They don't want to have a member put on a plan one year only to have that plan exit the next year and the member has to make a change. So I think it speaks to the need for stability and the fact that the carriers do want to provide that member the best experience. So if they foresee that a plan is going to be exiting a market, they may make it non-commissionable so that the enrollment slows.
Yeah, it's a sign. It's a sign. And of course, if you're not getting commissioned on a plan, then it's difficult for you to provide the service that you're supposed to provide. So they put you in a little bit of a moral dilemma in the short run because you want to do what's best for the client. But you also have to think in the longer run, the carrier is going to exit a market that they can't sustain, and they're going to try to be more diligent in what markets that they do enter. And so when they say we want sales in these areas, then we would expect the value prop will back that up, and we should probably take a look at that. Also, when it comes to stability, it takes a long time to get the medications right, to get the relationship with the patient right. So nobody really benefits in the industry for anybody moving around.
Right.
It's better to have a multi-year relationship. But unfortunately, the previous administration with the IRA and to some extent the current administration have put a lot of pressure on the carrier. So there's a lot of margin compression, and they've got to manage that. They've got medical costs up, and they have to be rational in how they do that. And so what we're going to see is more drugs are mandated to be in a certain price range on these plans. And that means that other drugs are going to be at a different price. So you'll see those benefit structures changing. So it's a little bit bumpy for the coming AEP. But Jackleen, I think there's also some good news, wouldn't you say, from what John Brooks and other CMS leaders have said?
Yes, absolutely. So at Medicarians, I know a lot of those that attended got to listen to John Brooks, the deputy director for CMS, and he really addressed some of the concerns that agents have. I was motivated to hear about the alignment that CMS has with the carriers. They understand the downstream impacts of policy and cost pressures that have on the market and the disruption beneficiaries are seeing. And I think that they want to see that stability in every member in an accountable, relationship with the provider and with the carrier. Also, they really encourage the agents in the room because they said there is absolutely an essential role for the broker in the current Medicare space and in the future. Mostly, he positioned, the broker as being there to help beneficiaries navigate care, costs, and quality. And he said if a beneficiary is not getting those things, then they don't consider that person adequately served. And another thing, too, that they talked about was just the fact that, brokers provide clarity and confidence. And those are the crises that he sees in the Medicare program where we really add value. It's not, just the enrollment. It's well beyond that. And some of the things that we've been seeing, of course, with CMS and how they're updating Medicare.gov, the National Provider Directory, and getting all those RFIs for their technology. There's a lot of concerns from agents thinking, am I just going to be replaced by a website or AI doing enrollments? And John Brooks and CMS was very clear that that's not the case, that technologies actually should be symbiotic to brokers. So there's a clear difference between just having information versus actually helping somebody translate that information to understanding. And we know that's where brokers create value in helping those beneficiaries understand the information, get on the right plan, then navigate all that there is afterward. So I was really motivated to hear that.
Yeah, me too. And we'll probably put some of those high profile videos on our website so they're easily accessible for our viewers. I would say that Jennifer really hit the nail on the head when she talked about quality. And people don't understand the unsung heroes that a full service community based broker are. And in our industry, the reason I frame it as equality is you could have someone who just got their license and just got a script and just passed AHIP, and they're, reading a script to someone and trying to do a needs analysis. And they're really getting paid, similarly to a person who might have 20 or more years experience, have hundreds of beneficiaries over time that they've cared for and are truly masters of their craft. And so sometimes the saying one bad apple, spoils the bunch is true. So we have to educate the government. First of all, Dr. Oz and Chris Klomp and John Brooks are just amazing leaders. I've seen them. I've interacted with them. I know you have too, Jackleen. So we're really fortunate to have such accomplished leaders. If they're watching, what I would say is the 5 quality metrics that I would encourage and are encouraging CMS to promote is, as a convener, is the accretion rate, the rapid disenrollment rate, the retention rate annually, the complaints to the plan, and the complaints to Medicare. I've spoken with all the major carriers and they have access to this data. CMS wouldn't need to pull or aggregate the data, but they should use their power as a convener to encourage the carriers to do that. If they don't do that, then the carriers are still moving forward to move towards quality, and they are creating their own metrics, but sometimes their metrics are more expansive in relation to the profit and loss, because most of them are publicly traded companies. And so they'll add other metrics in there about the pharmacy, and they're important and they're useful. But if we don't have a common yardstick with the 5 metrics that I laid out, we won't be able to see the bad actors that leave one carrier and go to another carrier. And quite frankly, the consumer deserves a consistent quality experience. There shouldn't be a range of 30% that don't accrete, whereas another agent 5% do. There shouldn't be 20% rapid disenrollments. If you take all 5 together, you've got definitely something that you should look at. Now, doesn't mean anybody should automatically be terminated. We want to be very respectful of people's careers and what can happen. But today, there's a lot of focus around complaints to Medicare, and that isn't a good metric to hang your hat on, because most of the complaints to Medicare are not founded, and many things count as a complaint that isn't really a complaint. It's a question about maybe your provider being in network. So if we can define those 5 metrics, we have to look at them by plan. So if, a D-SNP plan might have different parameters than a PPO. But that would be a simple thing that one letter from CMS and the top carriers could do that right now, and it would make a big difference in our industry. So Jennifer, what else do you see and hear in the marketplace? Are you seeing a lot of technology pop-up FMOs, a lot of acquisitions? What are you seeing in that?
I forgot who coined that phrase there, but yeah, we always have a lot of competitors out there, right? And definitely the pop-up FMOs. I can say that because there's a lot of us that have been in business for over 20 years, since the very first AEP. And so we've just tried to stay growing and consistent in the services and what we provide. And there's always new people entering in, especially backed by private equity and dollars, to try to capture some of the market share of agents and get into this business. Ultimately, I think that agents are attracted to those that are like them. We're really interested in trying to attract those top agents that are embedded in their community, that care about what they're doing, that are doing those post-enrollment services. And then we're giving them tools through Jackleen's client care team to help them with managing their book of business, so they can grow from having 300 and 400 in their book to having 1,000 in their book, right? So, we're really focused on those top echelon agents as much as we can be, or also taking agents that are not there yet and helping them get there. But we want to look for agents that are in it for the right reasons. It's real simple. I mean, I would even say this to every single one of our competitors. If we're all listening and trying to teach new people wanting to get in this industry that they need to do the right thing, that they have to actually care about what they're doing. Do they care about the beneficiary? Do they care about their grandparents? If all they're talking about is how much money am I going to make, how many in sales am I going to make, and they don't have those other higher order caring things on their mind, or we're not teaching them to have them on their mind, that's where I think we end up with a quality problem, right? And I'm all for people making a good living, right? We all can't work for free in the world, right? But those are things I'm looking for. I think that's where we got to get down to really change our industry. Look, Medicare Advantage works when you have everybody working together, all the different stakeholders, right? CMS is giving the proper funding to the carriers. The carriers are putting out plans that they can, have a good medical expense ratio, and they can pay commission to the agents and brokers. The agents being of the most quality that they can, educating and providing post-enrollment services, and then the beneficiaries through their agent and their support organization making sure they get in to see their primary care and utilize their plan benefits. All those people align up appropriately and we have a winning thing. And it's not all that bad. I hear a lot of naysayers out there. They're like, oh, we just need to use this new call center to enroll. We have the best. We do whatever's right for the member, regardless of whether we get paid or not. We don't need this drastic big change. What we need to do is the whole industry needs to work together to continuously improve. And so I think the 5 metrics you laid out, Darwin, are really good ones that we can look at and work together and make it happen, so. Yeah.
Yeah. Well, and you hit on a couple of really important points there too. It's a virtuous cycle. And originally brokers were kind of left out of the measurements in terms of the star ratings and other things. And they were more focused on how many MA enrollments, which is sort of where the quality problem erupted. Most of the training in AHIP and what you learn for your state license, it's only a small percentage of what you really need to know, maybe 10 or 20%. 80% of what you need to know is sort of tacitly taught, or it's an internal training program like we have here at Advocate. And so knowing how to do a good needs analysis and knowing how to unlock the benefits, you talked about post-enrollment services. Well, there's a 250-page, coverage document. So a beneficiary isn't going to be able to navigate that document and then take interest in all the different stakeholders and all the moving parts. That's where the brokers worth their weight in gold. And they're really aligned with CMS because the payments are aligned, the goals are aligned. A community-based broker has the state insurance license, and they are the trusted professional who's officially designated to advise the client on how to pick a health plan, how to pick a doctor, and how to navigate the system. So I think that the fact that they have goal alignment with the client, the fact that the compensation is aligned, the fact that they are the professional and that they protect when the carrier and the provider are sort of pointing the finger, that's where we resolve that. So last topic, I've seen a lot of the carriers are contemplating new commission structures. They're trying to move more into a value-based model. So my final question for the day is, do you think that the carrier should restructure the commissions based on maybe pre-enrollment, enrollment, and post-enrollment services? Or do you think maybe there should be a standard commission, which is what we've historically had, and we just raise the quality bar so that, people just don't have to engage with a low quality broker, and we remove or retrain or up the level up, the entire industry, as opposed to just having two kind of different payment models. I'll go to you first, Alissa.
Oh, that's an interesting question. So, I guess I can see it both ways, but I definitely think that quality and providing the service, like we always say, whoever does the work kind of should get the reward, right? So, like, if you have an agent who is high quality, who is doing what they're supposed to do as far as going through a proper needs analysis, like you mentioned, um, finding the best plan for that person, and then staying in contact with them, helping with those customer service issues, making sure that they're getting in to see the doctor when they're supposed to, helping them adhere to their medications the way that they're supposed to. I'd be hard pressed to say that broker wouldn't deserve that compensation, where you may have somebody else who just does an enrollment or sticks somebody into a plan, and then maybe that person never hears from their agent again. That's tough, right? So I also like the level commission amounts, because I think when we get into like carriers paying different commission amounts, like that's where things can get a little dicey. But I do think that a quality broker should reap that reward if they have high accretion, if they have high enrollment numbers as far as lack of disenrollments. They don't have a lot of rapid disenrollments, and low CTMs and low allegations. Those are all indicators of a quality broker that, should receive a fair commission for the work that they're putting forth. And it shows, there's metrics to measure that.
Yep, sure does. Jennifer?
Yeah, and I think Alissa has a really good sense of what's happening there with the quality, right? As the compliance officer, you're seeing a lot of you're copied your team on every single complaint that's coming into the carrier Medicare so that the agents can respond. So you're seeing some of those common things. So before I answer, I think it'd be helpful for the agents. Like, what's one or two of the most common ones you're seeing right now that really look out for that the carriers are watching?
Probably, well, the one that we see, number one, if you're talking about like reasons that we see for
Yeah.
CTMs and allegations, is did not consent to enroll. That's where the member calls the carrier or calls CMS and says they never, consented to enroll into a different plan. And in some cases, they might say that they were even unaware that they were in a new plan until they went to use the old plan and found out, hey, you don't have that anymore. You've now been enrolled in this plan. But we also see it happen sometimes with just a simple question asking. I think Darwin kind of alluded to that, where they might call up to ask a question and then it turns into something else. But did not consent to enroll is the number one reason. And that's where, call recordings and all of your scope of appointment forms, things like that
Well,
help
and
the
what's the
agent.
remedy? What's the
Mhm.
remedy there, Alissa? How do we stop that?
Well, I think a good agent, a quality agent, has all that documentation that shows that they did do a compliant sales presentation. If they have the call recordings, if they have the signed scope of appointment, I think that's a remedy, just that they've documented everything. Making those customer service phone calls after the sale, the 3, 10, 30,
Yeah.
60, 90-day phone calls, is huge. I mean, I can't stress that enough to agents. That is the
Yeah.
best way to head off an allegation, because you are keeping in touch with your member. They're going to call you if they have a question versus calling the carrier or calling Medicare. Um, and you're going to have those records of all those interactions that you've had with the member. The other one, I think that CMS and the carriers are closely looking at as far as broker quality, is making sure that the agent is using a proper enrollment period or enrollment code on an application. The FEMA disaster SEP is something that's closely being watched. Agents just need to educate themselves, and we provide training on those special election periods and how and when to use them compliantly. And those, I think, are some of the top ways that an agent can head off an allegation down the road.
Yeah, I
Well,
love that. Yeah, so to answer your question, Darwin, I know we had a little sidebar there, but it's relevant. I'm torn too, like Alissa. I can see it from both sides. I think, like you said, we've got to elevate the quality out there with the agents that are in this business, which gets down to making sure that the agent's adding value, right? We're all getting paid a residual to make sure that we manage that client. We've got to do our part and be in the industry for the right reasons. The money will always follow if you do the right thing in the way that it's structured today. So I think that's one thing that comes to mind. I do see that, as there's margin compression and we have more and more people enrolled on these plans, right? With 35 million, it's becoming a Medicare Advantage is now more mainstream and it's growing. And now everyone needs to sort of get the most out of every dollar, right? You always have that saying. So in that case, we really need to figure out how to squeeze out bad quality, elevate the good agents, bring new agents into it, and do our part and earn that, right? So I know there's a lot of groups trying to do that now, and I just think if we all get in it together, whether you're an advocate agent or you're with another FMO, we just all have to do our part and elevate it.
Well, I think you're right. And one thing that I think the industry is overlooking is that, and it's my favorite thing about Medicare Advantage, is I mentioned it's a virtuous cycle. Medicare Advantage is different than almost every other type of insurance because it actually helps you stay healthier. They want to catch a symptom before it becomes a disease. They want to get preventative checks and services before you have a symptom. And so, unlike wind insurance in Florida, I pay my wind insurance, but it doesn't really lower the probability of a hurricane coming. I pay for my auto insurance, but it doesn't really make it less likely someone's going to get in a fender bender. Medicare Advantage literally uses clinical and non-clinical tools to help you stay healthier. And so quality becomes much more important then, because in the beginning of the needs analysis and the education and the support to unlock the plan benefits, you actually help people stay healthier. They live better and they live longer. And so what you do on the front end as a quality broker has tremendous value down the road in what you've saved. And we've done some work now to show in a earnings per share for a publicly traded company is a pretty big swing. If you take the three top carriers and you just blend their financials and you're pegged on the high end of quality of those five metrics, it's 8 cents of profit on earnings per share. And on the low end of those quality metrics, it's a loss of minus 2 cents. And for those that don't know the financial model, remember when the health plans make 4 or 5%, which is about the profit that they're going for, anything over that, they take the money and they reinvest it into more benefits for the plan. And so you'll see some benefit structures changing here because of the financials. But ultimately, that competition it's why we have vision, hearing, dental, and other benefits. And so the system's working. We just have to make sure to keep the quality high. And also, I think in an efficiency, we want the government doing the things that the government can do well, making the program strong, making the program trustworthy. But the government doesn't need to do the carrier's job for them. The carriers and the brokers need to work together internally to keep the quality high. And in past years, the government made a lot of rules that were, I think, in some cases counterproductive to the goal, but they just didn't have another way. So if we could focus on those 5 metrics that I brought up and just use that as a yardstick, I think it'll really go a long way to cleaning things up. Well, with that, I'm going to say thank you, everybody. And I can't believe how time flew. We'll be doing one of these podcasts, AHA podcast, next week. And look forward to talking to you soon. Thank you, everybody.